So I am fortunate to moderate this next session, and we've been able to invite a really diverse panel here who brings a broad perspective. One of the things we've learned, Cupid and I, as entrepreneurs, is that you may have an idea, but what you really need to do is really test whether or not there's a need for it. You need to really ask it again and again and again, so that then you can really, as you are developing a solution, really refine it so it is impactful. And so we've invited 4 individuals who I have the greatest admiration for. I'm going to ask you to introduce yourself because you have such storied backgrounds and I can't do justice. Sachin, perhaps I can begin with you.
Oh, I wasn't expecting to go first. Thanks a lot for having me here. I'm Sachin Sinha. I'm Director of Technology Strategy for our federal health business at Microsoft. And you can think of my role as that of a Chief Data and AI Officer, spearheading our federal health business, serving a lot of our federal health customers. That includes FDA, CDC, CMS, all these. And Microsoft as a company, you probably know and familiar with and deal with day in and day out. But from healthcare perspective, I think you might not be aware that anything that you do from healthcare perspective, you are touching something from Microsoft. When you went to cdc.gov during COVID and checked the COVID symptoms using the COVID bot, that was built on Microsoft technology. When you're in a doctor's office and you are describing your symptoms to the doctor, and doctor is automatically putting those into the Epic system without hand typing those notes, that's using Microsoft technology. When you're ordering drugs from Walgreens, there is Microsoft technology behind it. So every aspect of our citizens' healthcare needs, well-being needs, there is some aspect of Microsoft behind it. And our goal as a company is really to empower each and every organization and person on this planet to achieve more. And the same thing goes for healthcare as well.
Thank you. Lori?
I'm Lori Dean. I'm an associate professor of epidemiology and oncology at Johns Hopkins. I'm a social epidemiologist, so many of the social determinants that Harry was talking about earlier is exactly what I study in the context of cancer and HIV. But I'd also like to add just one other point. I think this question about do we need it might need a little bit of a reframe. If you look at the United Nations, if you look at the United Nations mandates on health, part of that includes a right to health. And part of that right to health includes the right to education and information, including education and information about our own health. So instead of saying, do we need it as if this is a luxury or privilege, I think we need to think about this right to information about our own health as a universal right that's available to everyone and that we've internationally agreed is a right. What we really need now is a solution to operationalize that. And I think that's what we're here to talk about today.
That's a wonderful reframe. That's a wonderful reframe. Thank you very much. Kofi?
Yeah, so I'm Kofi Bohene. I'm a professor of head and neck surgery at Johns Hopkins, and I work with Harry Kwan, usually taking out tumors, and my role is usually to put people back together. And I've done that in the US
and fix my problems.
For many decades, but my interest in global health spans beyond the US. I've done a lot of work in Asia, South America, a lot of African countries. So this is giving me some broad perspective working in the US and working in places that on global scene we tend to term under-resourced countries. I don't like that word for various reasons. But it gives me that perspective. And so on one hand, I'm talking AI and how it's going to help me do work here. On the other hand, when I go to Ghana, I'm talking about access, quality, livelihoods. So bringing these two together is where my interest really lies.
Gary?
Hi, my name's Gary Ulrich. I'm very honored to be here because I'm just the people guy. I spent 10 years public school teacher, 1 year collegiate started a business that I ran for 43 years, serving the school market. So I'm still teaching is what I'm finding out in retirement, but I'm dealing with individuals because what we're talking about here isn't available to how many people have access to it. And so what I've found in my life now is first it was family people, then it was friends, and now it's friends of friends coming to me saying, how do I make a good decision? Is the information that I'm being given about the treatment that I should consider the best financial decision for the entity that I'm seeing, or is it the best medical decision? And so I feel that my role in what I'm trying to help people do now, since the product that we're discussing here isn't available, is to figure out ways to make good decisions about where they go, who they see, who they believe, and how to get there.
So Lori, I love how you reframed it because you're right. It's not only universal right, but it's very clear that we all see that there's a need here. Let me focus actually. For us, if we want this, what are the barriers? What are the fundamental barriers from each one of your perspective? Gary?
Access to knowledge. Even in my own case, I can go on my chart and look at what various service people have done for me, and it's so vague that it doesn't mean anything. And so I think that access to knowledge is very critical, and it's blocked right now. And the fact that two entities who provide medical care for me use that system. My urologist practice, they have something else. My vision practice, they have something else entirely. And so nothing is put together in a usable form.
So you're really talking about what we call data interoperability.
Yes.
So if we're going to do something, if we're going to make this effective, when we have to do something, we have to ensure that people are talking to each other, regardless of essentially the vendor. Sachin, how do you address that? How do you address that from a corporate perspective in terms of interoperability?
So data interoperability is it had been one of the biggest blockers in healthcare space. As we have heard the panel before us and in Cupid's presentation, data in different silos, staying in different organizations, different places, and not able to talk to each other. That has always been the problem. It's not that the standards have not been there. HL7 was there. Now there is FHIR, DICOM standards are there. But the technology to propel that into the next stratosphere, next level of a stratosphere was not there, which is now coming. And then in addition to data interoperability, a lot in healthcare really at the end of the day becomes a chemistry problem. When you start thinking of from the aspect of new drugs that needs to happen, when you start thinking of from the aspects of how different aspects of human body's anatomy interact with each other, it really becomes a chemistry problem. And in order to deal with that chemistry problem, we didn't have the compute until now. Now we have high performance computing, but that is still not pushing to the limits where we need to go. And that's where quantum computing is now coming onto the scene, which is going to take this to the next level. We will be able to solve eventually problems that is unfathomable right now for the compute that we have today.
So what you're saying is that we are at a point technologically where we should be, despite the fact that there's there's even legislation that requires data interoperability, that each one of us, if we wanted our digital health information, we can actually ask for it. But whether or not someone's actually be able to do so and give it to you is another matter. But we're just saying is that the ability for one system to be talking to another system fundamentally can and should be able to materialize like that at some point.
Yeah, absolutely. I mean, with the fire services that are available from, whether from Microsoft or from other cloud providers, now provide an ability for anyone to plug into, if they are using Fire Standard or if they are using DICOM standards, they are able to integrate with one single place where that data needs to come in order for us to make that analytics, make that aggregated conclusions on that data so that we can derive those meaningful insights.
So Kofi, you mentioned that you actually bring rather unique perspective, contrasting perspective, because you've seen healthcare delivered in North America and the challenges, and then you've also been you built your own hospital in Ghana. Speak to me about whether or not this kind of model that Cupid talked about can work either in North America from your perspective and what are the limitations, or in Ghana. Can we do this?
Yeah, this is a good question. So let me put my North American hat on first. Yeah, as a physician here, the biggest pressure that we have is time. It's finite.
Yeah.
And most of us who go into medicine, we love the human-to-human interaction. So as much as data technology starts to stand between us and patients, that we look at data and technology, and we lose the human touch, it starts pushing people out of our medicine. So when I talk to my Hopkins colleagues and we want to introduce AI and all that stuff, all they want to know is that, is it going to save me time? Is it going to allow me to have more time with my patient? Or would I have to collect more buttons? So it will be adopted in North America if it saves the physician time and allows them to be able to spend more time, human time, with patients. Now, let me put on my hat on experiences that I've seen in Ghana and other West Africa, other African countries. So we just opened a new hospital, it's a specialty hospital in Ghana. And I have access to some of the best world physicians and doctors and nurses who are not in Ghana, but splattered around the whole world. But then I have a patient who comes in with prostate cancer, and within a few minutes, I will connect them to the US, call a colleague in Mayo Clinic, call my colleague at Harvard. We have a diagnosis, they're good, right? The only problem, they have to upload their image. For me to read at Hopkins, I have to send the report to my colleague at Mayo Clinic and come up with a plan, right? So I think this could be adapted much more easily in a place like Ghana because there is nothing. You have a blank slate. So please, bring it on.
So you bring up a really fascinating point that regrettably, some of the incumbents right now may actually be a challenge. But then it speaks to whether or not, Laurie, whether or not we may not be able to readily adopt this for healthcare. This concept of decentralized EHR readily to facilitate healthcare. Hopefully, we can solve that. But for research, is that a possibility?
So
Can we bring that as a tool, mechanism to advance what we're doing right now?
I certainly think there's a lot of opportunities for research. However, I think we also have to be intentional about the design and the way that these systems are developed. So for example, I think electronic medical records gave us a lot of promise that we could answer these new questions and we could identify people for clinical trials and we could do all of these things. But then some of the rollout and the design wasn't such that we could readily use that information, as Kofi mentioned, in an efficient way. So I think if we think ahead and we have these opportunities to now recreate this system in a new way that allows us to pull data, not just from individual patients, but from their mobile trackers and other things that they're using, if we're bringing data together in a way that we can harmonize it, we can also make it so that it's designed to output information in a way that's organized and that's efficient and low burden for our patients as well as the clinicians and other users. And that's going to be a dream for researchers as well.
Great, wonderful. Time's coming to an end shortly, just like Cupid. I want to give you a moment. Each of you have had a chance to think about this. You're thought leaders in your own world. Do you have any parting thoughts on this for the audience and those who are listening to us by the link?
My observation is exactly what you were talking about. Time is a major issue. We also know that as a result of time pressure in profitable medicine practice today, the more services that could be provided have to be of help to us. In the meantime, I would encourage each of you to, whatever degree you can, to try to be a counselor and help people with how to go about making a good decision. I think that's critical in today's world, that they make good decisions based on research, information available, and the time that they have to put into it.
Thank you. Kofi?
I think the comment I made, I think, was made earlier on, that one of the goals of global health is to bridge the disparity, right? And if you look at Africa for now, the number of specialists, if we're talking about cancer, that are there, a drop in the bucket. There is no way we're going to train more specialists. And the only way we can bridge this gap will be through something like what we're talking about now.
Laurie?
I'm going to put my epidemiologist hat on, which means that I'm thinking about cause and effect. So as we think about using these tools, I think if they can be designed intentionally to answer meaningful questions about what the causes of disease are and how we treat those diseases and how that's working, we're also able to integrate some of the things that you both are talking about, as well as prioritize health equity. I think we have a real opportunity to close disparities, give patients autonomy, but then also ask and answer questions that we've never been able to ask and answer before.
And Sachin?
And from the technology standpoint, I think we are at an inflection point in the history of mankind where we are able to take really a leap of faith here. Whether that's federated learning that Cupid got into, large language models, generative AI, but also there is this new concept of small language models that is going to be extremely valuable for precision medicine and providing guidance at the right in the patient's hand. So these are the things that I truly think is going to go a long way in solving what we are trying to solve here.
Thank you very much. Again, I appreciate you giving us all a little bit of your time on Saturday, and hopefully we'll be able to improve care for everyone. Thank you.